I'm Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you're listening to JAMA AI Conversations. In this episode, we will be discussing the difficult and sensitive topic of suicide and support systems available for those in need. My guest today is Dr. Emily Haroz, an associate professor at the Center for Indigenous Health at Johns Hopkins Bloomberg School of Public Health, whose research spans the implementation of mental health and suicide prevention programs, particularly in partnership with Indigenous communities. Welcome.
Thank you so much. It's great to be here.
Thank you. So this is obviously a very sensitive topic, and especially dealing with populations like those from Indigenous communities. Can you tell me a little bit how you started this work?
Thank you. Well, first, I just want to acknowledge my colleagues who couldn't make it today, but are the backbone of a lot of this work. Many of these people and the people I work with work in their communities, their home communities, and are experiencing the repercussions of suicide firsthand. And many of them have worked for decades trying to sort of stem the tide on this issue. And so when I first started with the Center for Indigenous Health, the center at the Johns Hopkins Bloomberg School of Public Health over 9 years ago, I was really inspired by some of that work and learning about what all of their efforts to work towards preventing suicide and saving lives. And that kind of got me started in it. I'll just say that I've also now talked to dozens and dozens of people who have directly experienced suicide loss. And the sort of pain in those stories and the deep loss really resonates with people and with me and really touched me. And so I think working towards a world where we reduce suicide and we alleviate that type of burden and that type of loss and grief for families is really what motivates me in this space.
Well, thank you for that, and thank you for your work. And so because this is JAMA AI Conversations, we're talking about how AI is really transforming areas of medical care. And so from your perspective, how do you think AI will help provide and transform these mental health interventions, for instance?
So we know from literature published in 2017 by Franklin and colleagues that over 50 years of research on suicide prevention actually has yielded very little knowledge about what drives someone to suicide. And when you talk to a clinician or you think of people in your life or in the media that have died by suicide, we know that it's a multitude of factors and never one single thing that really drives someone to suicide. And so when we think about that complexity and the fact that really our past approaches, which have been largely focused on small regression models or risk and protective factors that have a few theoretically driven variables in them, that we haven't been able to make much progress. And so with all of that in mind, it sort of brought us to this idea of machine learning or AI, that we need methods that mirror this complexity. That if we continue to propose to do simple solutions for a very complex problem, we won't actually make progress on that. And so we think AI in this space may be able to be one tool we can use that mirrors the complexity of what drives someone to suicide and can help us in identifying them and making sure they get the care and help they need.
So can you tell us then, is what you see for AI really the identification of the factors that are increasing people's likelihood of mental health disorders or suicide? And can you talk to me a little bit about, some of those factors and what is put in the model and the methods that you've been using?
So I've done a lot of work recently on this idea of risk identification. This actually was motivated by stories we'd hear where people ended up dying by suicide who were seen in hospitals and missed. And most of the people we talked to, were saying, why would that person be missed? How could that person be missed? They were just visiting the doctor last week, last month. How were they missed? And so I think it's those stories that motivated this idea that if we really want to try and find the highest risk people, we need better solutions on how to find them. And so for us, this initial work has focused on risk identification, and we use that very carefully. We don't use prediction. That is a statistical term that people use. But for us, we try and focus on risk identification because that means it's not a foretold conclusion. It's something where we can identify someone in need of help, and we're not predicting their future. We're identifying them for help. And so for us, the models we've used have largely leveraged EHR data or community-based type data that's similar to an EHR, although collects different variables. And we've built these models, largely simple models. So these are AI models that are logistic regression-based regression classification trees, because those are the models that actually can be implemented right now in those places where we're working. We've tried more sophisticated models like neural nets, and those actually haven't improved our performance much and are much more computationally challenging. And so we've always kind of held this balance of trying to find and leverage AI when we can, but also being really careful about sort of the implications of that model and how it could be used going forward. And so the variables in our model largely derive from variables doctors and others have access to anyways. These are in the medical record. And what I like to think about with this is that these are just a way to synthesize information for a doctor. Increasingly in this healthcare environment that we're in, doctors don't have a lot of time. Looking over someone's history and all the factors that might put the person at risk isn't really a time-saving approach. And so what this model does is it synthesizes that information and produces scores that doctors can then interpret and make actionable. And in that way, we're looking at how do you identify risk and make sure those people get the care they need.
Do you want to talk a little bit about the results of that study and what those findings mean to you and how you would like them to be implemented in clinical practice?
In the article we just recently published in JAMA, we focused on actually testing existing models in an entirely new population. And so this is what's in sort of the literature known as generalizability or transportability of models. This is often not done in AI modeling. We see a lot of articles on building new models and some on sort of validation of models, but we don't see a ton that are externally validated. And so our basic question when we got this is funded by the National Institute of Mental Health, is the grant we have for this. We were going to set out to develop a new model for American Indian populations. But what we ended up sort of questioning first is, do we really need to start from the beginning again? You see many of these models built very specific populations. Is that necessary, or could you leverage work that's already been done? And we were fortunate enough to have great collaborators. So colleagues from Vanderbilt University, who we've worked with in the past, and colleagues from Kaiser Permanente, Washington, were kind enough to share their code and their model parameters with us. And we reconstructed their models using the data from the EHR system we were working in. And so we ended up fitting 3 models to this, 1 from Vanderbilt and 2 from the Mental Health Research Network that runs out of Kaiser Permanente, Washington. And using that data, we found that the 2 models from the Mental Health Research Network, one was focused on an ED model implementation, one was focused on a primary care model implementation, actually performed quite well. So when we evaluate their performance with the area under the curve, we saw 0.82 performance. However, the Vanderbilt model did not hold up quite as well, and its performance was 0.63. Its AUC value is 0.63. So that was a huge difference for us. That was very surprising. First, we did not think either model would hold up because the epidemiology of suicide in American Indian communities is quite different than other populations. For example, it concentrates in youth compared to the general population, which concentrates in older adults. So this was quite surprising that the MHRN models actually performed well. But we didn't want to stop there. We think of any AI model in our work as being additive to what we already do. Suicide screening is widely implemented. It's a Joint Commission best practice and quality standard. And this is something that's rolled out in many hospitals, including the ones we were working with. And so we wanted to look at AI models and their sort of ability to work with screening or how they compared to existing practices such as screening. And in the paper, we found that, again, the MHRN models outperformed screening quite significantly. So they had a URC value of 0.82, like I mentioned, and screening was about 0.63. That was even after we included many different types of way to sort of augment screening.
I love how you're not always having to create something from scratch. I think we do that too often, where there's a lot of really good models out there or a lot of good tools that are out there that maybe just need adaptation or recalibration to different populations. And I love that you actually externally tested it, which I think is more often never done and very much needed. So in this study that you had, it was within an American Indian population. And as you mentioned, the age group is lower, and there are also some potentially external factors that are increasing their risk. So For those that are building new AI tools and so forth, or even testing them, how do we ensure that they are culturally sensitive and that they are adapted towards the unique factors that are influencing the risk within these historically very vulnerable groups?
It's a great question. I will just say that all of this work is situated in sort of a broader landscape of our center having a long history of partnership and collaboration. So I say that both not to scare people away and say it takes 40 years, but our center has been working with this community for over 40 years and done some very innovative other studies, not related to this and AI specifically, but to many other things. And in that partnership, you build trust, right? And so it's through decades of mutual trust building to allow this kind of work to go forward that really stands as sort of the backbone to much of this work. Specific to our AI modeling and that approach, again, what I found was that it was motivated from stories from the community of people being missed that really started this work. For the past year, we've been working on participatory approaches to understanding how this model could be implemented, both in a federal healthcare setting, but also from a community perspective. And so we've done interviews with community members about the acceptability of this type of model, whether they want it to be used, how they want to be communicated around it as well. So we're doing a lot of participatory community engaged work to address some of those cultural concerns and listening. And we have a community advisory board in our sites that is advising us on these approaches, and we've learned really valuable things. And so I think as you go forward, I don't think there's enough of this. I've seen it in the literature as a recommendation of really situating the community and ensuring that the community has a voice when we're building out tools, even from the very beginning of conceptualization up through implementation, and ultimately, if there's need for external validation or recalibration, that communities are part of those processes going forward.
And so is what you're saying is that AI can't solve everything. We do need to do the on-the-ground work, and we have to work with the community, and that is very important to both have AI as well as have traditional interviews and qualitative research be involved in the making of these types of interventions?
Absolutely. I can't imagine doing this all with AI. I think the voices of our providers, our clinic administrators have been really influential in us in thinking about what's the protocol for patients, how would this implicate workflows for really low resource places where there's not enough staffing. And then the community voice has guided us along the way to really voice their opinions about it. What are their ethical concerns? What are their hopes for this tool going forward? So I absolutely think AI can't solve it all. And in fact, I'll just tell you some preliminary work we did. I learned that early on. We developed a model outside of the EHR in a community-based system to help community case managers with prioritizing who they would visit first. And in that process, one of the things we did was we interviewed the case managers and we asked them, how do you know when someone's at high risk? And almost all of them mentioned that the person was crying. And AI right now, unless you have a tool recording that information, can't pick up on that. They sort of see the situation, they assess the context, they know the patient's crying. And in that process, we learned a lot that humans have to be at the forefront of this. And so what we ended up doing with that tool was we kind of switched our cutoff values. So most people think like when you develop an AI tool for suicide, you want to maximize your sensitivity, you want to maximize the chance that you won't miss people. But in fact, what we found out was our case managers weren't missing those people.
That's a really, really good point. I think you need humans to be a part of the research, and you also then need humans to be part of the assessment and the intervention. I don't think we can ever exclude them. But let me ask you then where things can go wrong in terms of using AI and the ethical issues around using AI models for the detection of suicide. I guess what I'm asking you sometimes is, do you ever worry that AI will be used too frequently and we will miss suicides? Or do you think it's actually a little bit better than humans in the way that maybe we're going to highlight it a little bit more?
No, I think I have worries. I mean, it's known that there's alert fatigue, there's over-reliance on these tools once you get them, and that is a known phenomenon. And I think we have to carefully think through what are the repercussions of sort of trusting the tool too much. and not questioning it. So I definitely have concerns about that. The thing that I like to think about, though, and maybe it's an error, but is that these tools aren't used in a vacuum for suicide. So none of our tools that we use right now undergo such critical evaluation. There's not a single suicide risk screener that's validated for an American Indian community, despite them having the highest rates of suicide. So we're spending a lot of time and scrutiny on AI, and we haven't done that for other ways that we leverage suicide risk identification. I think it should be done for all. I think that's critical for all. So, and I know there's great work that's actually going on to hopefully provide us some answers on that by colleagues and others. So I think there's a real opportunity to learn about that.
And so what is your next step now? You said, you've got funding, congratulations, from NIH. And you'll be wanting to conduct a clinical trial. So can you give us a little teaser or tell us a little bit more about your next steps?
So we are working towards launching a fully powered clinical trial where the tool will be implemented in care, and we will refer people to case managers in the community who are from the community, oftentimes called community mental health specialists. And the idea is that if we know there's a bunch of people at risk, can we provide them with compassion and human care before they come back to the ED for another thing or even worse? And so the trial will launch in partnership with 3 sites in the Southwest. We're really excited about it.
So how would you like this AI suicide risk tool to be implemented in practice? So hopefully it's not this long, but 5 years later after your study is all done, how would you like to see that be implemented, and what changes would you like to see just in healthcare when it comes to suicide with this tool?
Well, first I should say, if we're successful in showing that it works, and also our second aim of this study is to monitor the costs of this. I don't think costs are talked about quite enough in modeling, but really thinking through, do the costs outweigh the benefits, or do the benefits outweigh the costs in this case? So assuming we end up with an effective and cost-effective tool, we'd like to see it implemented across Indian Health Service, potentially other health systems as well. The 2 use cases that it can be used for is, one is as a tool to prompt clinicians to probe and ask more questions. And this is the use that some health systems have taken on with these tools. The other case has been what the VA has done with their program called ReachVet, which is to prompt proactive outreach. And this is what brought our clinicians that have commented on our model have really identified as the hope. And so that tool being rolled out would prompt a caring contact type of follow-up that would hopefully prevent the behavior or the risk from escalating going forward. And so I think the ideal is that it grows and serves more people, but we only want to do that if we know it's effective going forward.
Great. Well, thank you so much for being here and sharing your insights. Thank you.
Thank you.
I am Yulin Hswen, Associate Editor at JAMA and JAMA Plus AI, and I've been speaking with Dr. Emily Haroz about leveraging AI to develop mental health and suicide prevention tools. If you or someone you know is struggling with suicide, you can call or text 988, the National Crisis Line, or go to 988lifeline.org. You can also find a link to the article in this episode's description. And for more content like this, please visit our new JAMA Plus AI channel at jamaa.org. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network whenever you get your podcasts. This episode was produced by Danielle Moreau at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.